Kristen said, I work in Bristol, where we've taken on the Southwest cervical cytology work. And so I've just chosen a few cases that have come through HPV primary screening. There's a mixture of things. Some are a bit more tricky than others, because I wanted to have a range of cases because I wasn't quite sure who'd be on the call. So I'll make a start. Okay, so case number 1 then, we have a 53-year-old patient. She had 2 recent cervical samples that were HPV positive, and both of those were cytologically negative. So as with the HPV primary protocol, if you have HPV positive, cytology negative, you come back every year until your 3rd occurrence, and regardless of what that shows, if it's positive again, you go to colposcopy. So she came back for her 3rd sample, was HPV positive, and so we had a slide prepped for cytology as we would. And so I've got a few pictures of cells for you to have a look at. So on this first one, hopefully you can see it's a bit of a thick group, so a bit tricky to photograph well, but sort of look a bit endocervical, and then you've got, you can see just remnants of mucin throughout the top layer of the cells. And some more groups, so we have again some groups for you to compare on this one, but similar sorts of appearance to that first image. So we have rather thick sort of group, and you can see again these sort of mucin vacuoles at the surface. Again, just a higher magnification of that group so that you can get a bit more detail, so that you can see the individual nuclei as well. And a different group, just a little bit, I've photographed this one just because it's a little bit easier to see the nuclei, because the group isn't quite as dense as some of the other ones in there, but you can still see that you've got these mucin, areas of mucin within the epithelium. And just a high power view of the nuclei for you, so that you can have a look to see if you can see any clues when you see a bit more detail of the individual nuclei as to what you might think about this case. Okay, so the first poll, thank you to Christian for sorting the polls out for me, if it's going to work, that is. So what is your opinion on the cells that I've shown you so far? So would you be opting for benign endocervical cells, borderline changes in endos, CGIN, high-grade squamous dyskaryosis, or tuberoendometrioid metaplasia? So we'll give people, so you can vote by clicking on what you think it's showing, and then Christian's going to keep an eye on that just to see when we've got a few answers. I didn't put I don't know or I don't want to answer, because that got to put something for me.
I think we've had 20, oh, it's still going up, so I'll leave, I'll allow 10 more seconds.
So we need the countdown clock. Oh, there we go. So we've got quite a range of answers. And I appreciate, I have to say, that looking at photographs from a case is not the same as looking down a microscope at all, is it? So give me a microscope any day and I'm much happier. So we've got a range of answers here then. So we've got some of you, I don't know what 11% equates to numbers wise, but thinking benign endos. Just about the majority saying CGIN, and then another big majority saying borderline in endos, a few high-grade squamous, and then a few people thinking it could be TM. So I guess from the poll here, then we've got that the majority of people are thinking it's abnormal endocervical type of cells. Okay, so thank you for voting. Okay, so the lab opinions on this case then, first of all, the primary screener decided that it looked negative because there was lots of normal looking endocervicals, and they could see some mucin and thought that the morphology looked okay. It was picked up on rapid review as query abnormal groups of endocervical cells and passed through to a checker. The checker again was thinking that architecturally some of the groups looked a bit wrong, but there was this sort of mucin which was a bit off-putting, and they thought it was possibly borderline in endocervical cells. And then the final report went out as a CGIN. So, okay, so the patient went on and had a LEPS done, which did show, in fact, CGIN. So you've got some normal columnar endocervical cells here, and then we've got some much more sort of stratified looking endos. I put those groups for comparison there. And then there were also these groups which, again, showed, these are glandular, this is glandular epithelium in the endocervix, and it's showing very positive staining with P16 here. And you'll see that these groups, although you can't see morphologically too well, these are groups showing features of CGIN. And then you've got these other areas here with massive big sort of mucinous vacuoles, sometimes sort of filling up the whole of the cell. And in these darker staining groups, again, you can see that you've still got these mucin vacuoles within there. So this patient had high-grade CGIN and some of the sort of intestinal type changes, which we see with all those sort of goblet cells and mucin production. So here's the outcome that you've got here. So the first LEPS that the patient had showed, as I said, high-grade CGIN with all these mucinous changes as well. It was incompletely excised. There was no CIN or SMILE, which is perhaps the other thing that you might think about with some of those cytological features. So most CGIN is, as we know, associated with high-risk HPV, and some, but not all of the intestinal types of CGIN are associated with high-risk HPV, but the majority of them are. Occasionally you do get cases in particularly older patients that actually do not stain positive for high-risk HPV or P16, which is a surrogate marker for that. But in this case, because we had that block sort of dark P16 positive staining, then that would show that this case was actually linked to high-risk HPV. There is, if you do have cases that are not linked with high-risk HPV, then I guess that does make follow-up with just HPV primary screening quite tricky. And we've had some cases come through via MDT where colposcopy have wanted us to follow up with cytology. And so when they've requested that, what we've asked them to do is to actually get the histology tested to check that whether or not it is linked to high-risk HPV. And so far, we haven't had any cases through that are not linked to it. So we're just following these up with HPV primary as we would normally. So the outcome for this case after her first LEPS is, of course, it was discussed at MDT to double check about the margins, and then you've got the option of what to do next. So this patient was put for a second LETS, which again showed residual CGIN but complete excision on the second LETS, which is often the case. So this patient, she's now planned for a test of cure, which if it's negative, of course, you'll have to have a second test of cure at 18 months. So because of the CGIN. So for this case, really, it was just to think about those endocervical cells that we could see on the cytology, and to always look on high power, particularly when you've got sort of thick looking groups of endocervicals, even if you can see mucin within those groups, it isn't always showing that nice honeycombing effect that we would expect to see. And if you look through the groups, then hopefully you will then notice if there is any disturbance to the architectural features of the group. So just remembering that some CGIN does have abundant mucin in it. Okay, so then that's just to show you those groups again. So again, it's this sort of appearance which you can sometimes see when you have something like SMILE as well. We don't tend to, well, I don't tend to try and say if I think something is SMILE or intestinal type of CGIN on cytology. But sometimes you look at groups and you think, oh, it might turn out to be, and so it's nice to look up the follow-up on these. And then on high power, I think that one of the difficult things about this case is that the nuclei all look fairly bland. The chromatin isn't particularly abnormal looking on these groups, on the nuclei on high power, but there is a disordered nature to the groups here. And if you look carefully, you can see some very large abnormal looking nuclei that are certainly not within the realms of normal, and this disturbance to the arrangement of the nuclei here, again, I would not class this as normal. I think there's too much crowding. I think there is some sort of variability within this group as well, which isn't always necessarily typical of the CGIN, but then again, it isn't quite normal either. So again, just the staining intensity of the chromatin within these nuclei, and some of them you can see is looking a little bit coarse, but for me certainly not negative, and so at least borderline endos. And then there were some other groups which won't photograph particularly well, which I think added weight to the opinion of CGIN, which is what it was reported out as, because you just had quite a lot of stuff within the same slide. Once you got your eye into the thought that actually these might be abnormal groups. So just really to be wary of those sorts of groups in your cytology. Just a mention of SMILE versus the intestinal types of CGIN. Cytologically, I guess if you sat down with lots and lots of cases, you might be able to find some features to distinguish between both, but the ones I've seen all just have those similar sort of vacuolated mucinous groups. But with SMILE, you actually have some sort of stratification to the glandular groups here, and you'd also see mucin throughout the epithelium, which you wouldn't expect to see mucin throughout in something like metaplasia, whereas with the intestinal type of changes, then you don't have any of that stratification. The other thing to say about this case is, of course, that this patient developed CGIN despite sort of engaging with her screening invitations. But I guess the good thing about this patient is that because she was coming through HPV Primary, that even though her cytology was negative on those last two tests, that she was insured a 12-month repeat each time. And so it adds opportunity to get a good sample, a good quality sample for the cytology. So had she not come through HPV Primary screening, then of course, on her negative cytology 2 years previously, she would have been put onto 5-year recall because of her age. And so who knows, if it had been left for another few years, would her CGen have progressed to anything worse? So I think this patient has benefited because of HPV primary, but she also ultimately benefited because we got a good quality cytology sample to look at. The previous cytology samples, as you might have expected, actually didn't have any endocervical cells present in them, which of course we don't need endocervicals in a slide to call it negative. So they were correctly reported as negative. And that's really just a limitation of cytology. We are still reliant on a good sample for the result to be reliable. Okay, so that was the first case. I don't know if anyone's got any questions.
We do. We have just one at the moment. When you look back on the previous two slides, were there any TZ presence or not? So you've actually answered that one.
Yeah, so I mean, it does, you know, in cases like this, we often talk about the fact that HPV primary might miss certain cases. But then I guess we have to just remember that even when we have cytology, sometimes we're going to not see things because the sampling is often an issue for CGen.
Okay, yeah. Thank you for a well-presented case again.
Okay. You have to shout at me if we're running out of time though, okay?
No, we're okay for a while, you grant.
All right. Okay, so some of the cases are a bit shorter than that one anyway. So the next case I've chosen is a 62-year-old patient who is on routine recall, and she's high-risk HPV positive. So I've just got a few images that you can have a look at. So it's just sort of a low-power image of some cells that were on this patient's slide. Pardon me, and just a higher magnification of some of those similar cells. And here's another area on the slide. So we've got sort of two groups that you can compare. And a higher power magnification of one of those groups. And something else. Okay, so poll number 2 then. So what's your opinion on the cells that I've just shown you? Are we looking at just negative changes associated with atrophy? Would you call them borderline changes, low-grade dyskaryosis, or high-grade dyskaryosis? So if you want to vote now.
We'll give just 15 more seconds, Helen.
Okay, thank you. Okay, so again, a range of answers, but the majority, so 63%, going for high-grade dyskaryosis, and a few people, again, would have called this negative atrophic changes, and then the rest borderline or low-grade. Okay, so this case was reported as high-grade dyskaryosis. She went to colposcopy. Colposcopy was unsatisfactory, so they performed a LETS based on the cytology. And in fact, the LETS showed CIN3. So the cytology was actually correctly reported. So for those of you who went for high grade, you were correct. For anyone else, here's just a reminder really of the features that we would want to think about when we're trying to consider if we've got dyskaryosis in an atrophic sample. So the first thing I would say is to think carefully if you're seeing sort of two distinct populations of cells. So if you've got some groups that show quite reassuring features of atrophy, but then you've got some other groups that maybe just look much darker or variable nuclei. There are issues with atrophic samples in that the samples themselves, even with thin prep, are not always that well preserved because there is that tendency for that slight air drying. And there's tendency for the epithelium to be quite inflamed or for the epithelium to bleed when the sample's taken, all of which might hamper interpretation. So you do need to look closely on high power at some of the groups. The nuclei can look a little bit bland, as I've said, because of those difficulties, but they will show some variability, at least in sort of size, shape, and arrangement of the nuclei. And borderline changes is, another option, isn't it? If you have genuinely not certain that you're looking at dyskaryotic changes. So I don't think borderline was an unreasonable option if people chose that for these cells, particularly when you're just, as I say, looking at photographs rather than the slide itself. So I put just these two groups back up because hopefully by looking at the top group here, you can see that is definitely showing just normal atrophy, normal parabasal type cells, but note the uniformity that we've got with these nuclei if in terms of size, shape, texture of the nuclei. Some of them are appearing a little bit darker, but that's just because they're sitting on top of another nucleus. So if you had the luxury of looking down a microscope, you could focus in and out on those nuclei and see that they're very similar. If we look to the group down the bottom here, then hopefully what you can now notice is that they do look a bit different to that normal population of parabasals at the top, in that we have got some quite enlarged, dense, dark nuclei. Admittedly, you can get some quite marked changes in atrophy that turn out to be nothing, but I still don't think we can discount these sorts of changes on the cytology. So I'd say not negative, at least borderline, and certainly I'd be considering whether some of these were showing me enough features, if I could look at them more closely, to consider whether they could be high-grade dyskaryosis. And then if we look at this higher power magnification of some of these nuclei, on the left we've got some of those normal parabasal nuclei, and on the right, hopefully, you can see, which would probably be a bit more of the what you might get if you were looking down the microscope at these, that detail that will allow you to compare and contrast these nuclei to actually see we've got the variability in size and chromatin texture in these. So careful examination on high power. As far as HPV primary screening, we know from the data from years and years ago from Artistic that as patients, as women get older, the likelihood of them having HPV diminishes, although some women do manage to hang on to their HPV. As somebody gets older, once if they've either picked up a new HPV or their HPV is flared up again, they do find it more difficult to for their immune system to sort of fight off the HPV. So they are prone to hang on to their HPV once it's flared up again. And we know sampling and cytology can be a challenge in these patients. Often for the postmenopausal cervix, the os is very small and difficult to get a good sample. You can't really see the TZ because it's inside the canal and not visible, for instance, at colposcopy. So this can make this group of patients quite challenging. And if we can get the cytology right, if it's high grade, then that's really good, because we're probably one of the most reliable things when we can see that abnormal chromatin is to actually report it on the cytology. As I say, Colt might not be able to see what they're looking at, so it's very difficult. They'll often be left with no alternative but to go for a loop if we're calling it high grade, or if we're calling it low grade, so those of you who called it borderline, it's whether or not they're prepared to do a LEX on that, or whether they'll just keep choosing to follow up with annual HPV testing. So it is a challenging area, so I thought it was worth including just to have a reminder of those features, because we often don't see that much of it in the atrophic samples. So it's an area I know people get a little bit worried about. So any questions in case 2?
Hi, Helen. Yes, we've got one. Is the morphology challenging on histology too? You know,
I believe so. I mean, I'm not a histologist, but just from looking at cases side by side where you see atrophy and SYN3, that, you know, for the most part they can look quite similar, but if you look closely at CIN3, then you would hopefully get some things like mitotic figures and altered, you know, changes, morphological changes to the nuclei. But then I guess you could use something like a P16 if it was a tricky case, which I know sometimes our pathologists would ask for a P16 on atrophy. So it's no, you know, it is challenging on cytology, but it's just a challenging area, full stop, I think, trying to screen these.
Great, thank you. I don't know if anyone else has a question before we move on.
Okay.
I think that's it, Helen, yeah. Thank you.
So I'll move on to case number 3 then. 33-year-old patient has had 2 previous LETs for CGIN. So she'd had CGIN diagnosed on her cytology, had a LETS, CGIN again, had another LETS. So she's 2 LETs in, and then this is her follow-up at colposcopy, and she's HPV positive, so I should have put that on here. So colposcopy, done a broom and a brush on this patient. So that's there were some groups like this in the sample, which you can have a look, see what you think of these ones. So a little bit dense, a little bit crowded. And another one. And then this one. So for the third one then, what's your opinion on those cells? So are we looking at benign glandular cells, sort of post-treatment effects, TEM or LUS? Would you go for borderline changes in endocervical cells? Would you go for CGIN? Has she still got disease? Or would you go for something else? So if you want to put your opinion.
I'll give about 15 more seconds, Helen.
Okay. Okay, so again, a range of answers. The majority have gone for CGIN, but that's less than half of the people on the call. Quite a lot going for benign glandular cells, so thinking TEM, LUS, a few borderlines, and other. I'm not sure what that other implies though, but it was an option I gave you, so that's fine. Okay, so if we can close that, thank you. Okay, so this one was reported as difficult to interpret, cannot exclude residual CGIN, but the bottom line, it was put out as borderline endos, and I'll hold my hands up to say I reported this one. I think I sat on the fence a little bit. I think I was concerned that she'd already had 2 LETSs, that she was only 33, and if I went for CGIN, that they would definitely do something quite drastic for her. So it went for discussion at MDT, and when we reviewed it at MDT, the review, it was thought more likely actually it was showing us changes associated with CGIN. So I guess those of you who have put CGIN, then that's really what it should have been reported as. But if you went for borderline endos, then you were in my camp. So patient actually went on and had a hysterectomy, age 33. And her hysterectomy sample in the cervix, she had areas of residual CGIN. You can see that some of the very dark brown staining with the P16 showing you some areas of CGIN. And then her CGIN actually extended all the way up to where her endometrium was as well. So it was going the whole way up, basically. So actually, the cells were actually showing us, I'm just going to go back to them for you, likely these were actually from her residual area of disease. So I think it is tricky though. I think, we know that with things like LUS and TEM that, they're quite a mimic for CGIN. But I think particularly this group, I think is quite difficult. It's got that almost straggly look to some of the cells. This one, you could be thinking, has it got sort of hard edges? But I guess when you start to look at it a bit more closely, maybe there is a bit of a jumbled appearance to it, and perhaps it doesn't have those tidy sort of edges that you might expect. And this group here, I guess if you're comparing to these normal looking endos here, we've got quite marked sort of pseudostratification here. But I still think the chromatin isn't that bad on these ones, but architecturally it should be quite worrying. So definitely not benign. And so I've just put some pictures of, the sort of benign changes we might expect post-treatment. So if we look at, the elephant trunk sort of LUS type, it's got much sort of straighter edges to these tubular structures, bit of TEM in this top corner with got some ciliated cells there, and still a fair bit of cytoplasm, which we perhaps didn't have in the groups in this case. And then just some other typical features at the bottom that I'm sure we're all aware of that we might see with LUS. So just a few notes really. Post-treatment for CGIN, it's really important to ensure the margins are clear, and I think this case demonstrates that really well, the fact that sometimes it can just be present all the way up the canal. Consider post-treatment effects, but don't rule out the fact that there could be residual disease, and I guess you shouldn't be put off by the patient age, but it is difficult, I think, in day-to-day reporting to not think about that, particularly in these cases where we don't see that many of them where 2 LETSs don't work. And if we're going to call something borderline endos, I think we ought to be thinking, how worried are we about the likelihood of CGIN? And might it be more appropriate to actually code as CGIN but express doubt in the text? And I've just put a note that perhaps we should all be auditing our outcomes for borderline endos. We did this recently in our lab. You know, and 39% of our borderline endos turn out to be SIN2 or worse. But what I have said is, particularly now when you've taken on work from other areas, getting histological outcomes does become a bit more challenging, although these cases should end up at MDT, which would help. Okay, that's that case. Any questions?
Okay, Helen, there's none that I can see in the chat at the moment, but
okay.
Again, I thought that was a really interesting case, and obviously quite a young lady again. Yeah.
Okay.
Okay, yeah.
Okay, case number 4 then, 49-year-old, routine cervical screening, irregular bleeding, high-risk HPV positive. And I've just got 2 pictures to show you. So there's that one. And we're looking at these cells, and then that's a slightly better view of the cells. And that was pretty much it. So, okay, so if you make your mind up then. So for this one, what would be your opinion? Benign cells, high-grade squamous dyskaryosis, CGIN or cervical adenocarcinoma, or a non-cervical glandular neoplasia. So if you want to vote in the poll the Christian's put up now, that would be great.
We'll give about another 15 seconds, Helen.
Okay, so we've got, again, a range of answers here. So the majority thinking non-cervical glandular neoplasia, closely followed by CGIN or adenocarcinoma, and then a few for squamous disc, and a few people thinking these were benign changes. Okay, so if we close that. Okay, so this had quite a long-winded report on it, but the sort of bottom line was possibly a non-cervical glandular neoplasia. So the patient underwent endometrial PIPAL, and her PIPAL actually was full of adenocarcinoma cells that showed strong positivity for P16. And she then also had a LETS performed, which showed CGIN and adenocarcinoma identical to what was seen in the endometrial PIPAL. So this patient, it wasn't non-cervical, it was actually a cervical abnormality, cervical adenocarcinoma. And the cytology for this, it didn't look like directly sampled cells particularly. There wasn't hardly anything there, just this sort of 1 or 2 groups. So it could be that these cells were actually shed from her cancer that was sort of had gone up to involve her endometrium. There was nothing visible at colposcopy when they saw her and her previous cytology samples were negative, but no TZ again. So again, this is another lady who this time's developed cancer despite engaging with the screening program. And the cells really were picked up by chance, I think, on our cytology. So for those of you, I'll just put that last group back so you can have another look at them. For those of you who called it benign, I do think they look a little bit concerning. I think they're a bit variable. We've got some irregular sort of contours to their nuclear membranes, and the chromatin just looks, it worries me. I'm not sure that they're certainly not typical of CGIN features, and I guess that you just look at those and think, well, they're either coming from adenocarcinoma, most likely sort of endometrium if we've not got much on the slide, but actually it was cervical. And this big sort of dirty mucinous sort of vacuole there is, again, not typical of just inflammatory type change, if that's what people were thinking. So that was just a short one for you. Don't know if there's any questions on that.
No, none yet. But again, I think that's a really nice case where you had nothing else to compare to if that's all you got. And I would have said it seems to map more to maybe something that shed and was degenerate as well as abnormal.
Yeah,
and you're seeing those features maybe.
So, you know, it's sort of luck more than anything that we got those cells.
Yeah.
Okay. I'm conscious of the time, so I'll move on to number 5 then. So a 28-year-old patient, first smear. And it's just a few groups to show you. So that's one group. Another slightly more sort of crowded group. And a higher power to show you the chromatin. Okay, so poll number 5 then, if you want to vote, if Christian wants to put this one up. So do you think we're seeing negative changes, borderline in metaplastic cells, high-grade squamous, or CGIN?
We'll give just another 10 seconds or so.
Okay, so range of answers, no negatives, which is good. I thought, yeah, I was hoping nobody'd go negative on this one. So we've got majority high-grade squamous, followed by CGIN, and just a couple of people thinking borderline in metaplastic cells. Okay, so this was reported as high-grade severe dyskaryosis. I'm just going to go back to this slide really. If anyone who thought borderline, I think actually these are showing definite features of abnormal chromatin here. We've got irregular notches to the nuclear membranes. There's a disordered arrangement of the nuclei. If we look to the edges of the group, there's no, the nuclei aren't polarized to any particular direction. So to me, looks much more in keeping with squamous dyskaryosis than glandular. Some of the cells, I agree, just looked a little bit like they were mimicking CGIN, but the thing is, if you compared those nuclei to the nuclei in the more classic squamous dyskaryotic groups, then actually the nuclei were quite similar. So she had a LETS, which showed CIN3 going into glands, which again might mean you've got endocervical cells at the edges of some groups. And she also had a small focus of squamous cell carcinoma. Her CIN went up to the margins, so she had a second LETS, which was actually clear of any CIN. So we have a patient who's got SIN3 and squamous cancer. She's had her 6-month follow-up, which was HPV negative. So then she's now on annual follow-up with HPV for 10 years, and she'll only have cytology if she's HPV positive. So of course, for this case, we need to undergo cancer audit because it's a cancer. So if you think back, she's a 28-year-old, it's her first smear with this class as a screen detected cancer. I don't have a poll for this, but you can think about, would you say yes or no to that question? So it's high grade, picked up on cytology. Is it screen detected? And the answer is actually no, it's not classed as screen detected because this patient had defaulted from coming for her invitation for screening. And if somebody is 6 months or more late in attending for their test, then they're not considered to be screen detected cancer, which is sort of a strange one because most people might think that if it's picked up on cytology, it was screen detected. But we had this clarified in a recent meeting, so it's just thought I'd share that with you. In the latest cervical cancer audit report as well, it does show that there's about a 25% increase in non-attendance among the younger women that are diagnosed with cervical cancer. And there's an increase in early stage cancers being picked up in these younger women. A lot of that is attributed to HPV testing, but there's certainly a group of patients where we need to really try and encourage attendance for that first sample at 25. Of course, we've got the vaccinated cohort, the fully vaccinated ones coming through for screening in England now. So it might be that we see a decrease in these figures over the next few years, provided they come for screening, of course. Okay, so any questions on that one?
Okay, Helen, I think you're just providing so much information that you're answering everyone's questions at the moment.
Either that or people are just having a little snooze, I'm not sure. But okay.
No, but yeah, but again, it's such a young age to see someone with the, focus of squamous cell carcinoma in there as well. But but that's where education for the screening program is going to come into play. Yeah, now we're 25 past 3, so I don't know if you've
last one.
Yeah, that's brilliant.
It's a quick one. It's a quick one.
Yeah, so, no, I think so. Thanks.
32-year-old patient, routine sample, high risk HPV positive. So we've just got 2 groups to show you. That's one, and higher power magnification. So, what's your opinion? So if we have a quick poll on this one then, Christian, so are we looking at multinucleated giant histiocyte, herpes, high-grade squamous dyskaryosis, or adenocarcinoma? Okay, if we close that one now, I think, Christian. Thank you. Okay, so, right, lovely. So majority of people, but only just less than half of you gone for herpes. Some people got adenocarcinoma, so my plan worked, it's fine. Okay, so if we can close that one. Thank you. And so this is actually from herpes. But it is a bit of a pitfall, particularly when someone only shows you one group of cells to interpret, which is very unfair. And so these are showing viral inclusions, but I put for comparison with adenocarcinoma in this slide. But you can see you've got lots of cytoplasm actually in the herpes on the right, but there were other areas I could have showed you on this slide that would have made interpretation an awful lot easier. So And I think that's my last one. So thank you very much for staying on. I hope you enjoyed the cases. Any questions, feel free to email me, or, I think that's it.